Good evening, everybody. We'll give it a few minutes so some other people can join us. I'm going to wait till about 10 after to see if anybody else joins for you, those of you that are on. That's what we're waiting for. All right. It looks like we've got some more people joining, so we'll go ahead and get started. Tonight, can y'all see the PowerPoint? Can y'all see it? Somebody's got to talk to me. Otherwise,
No, Professor.
No.
you still can't see it?
Yeah.
No.
No?
Yes.
Yes, we can see it now.
Okay, great. So, good evening, everybody. I'm Dr. LePage. I hope y'all are doing well. Tonight, we're going to talk about childhood oncological disorders. So, when we think about oncology or cancer with kids, what's the first thing that you think about? What's the first thing that comes into your mind? Pain. Could be pain. Yeah. What would be a priority thing that comes into play? For me, what I think of is as a priority issue or something that I need to manage is to prevent infection in these patients. Because remember, they're already immunocompromised, and it doesn't matter what type of cancer it is, we need to prevent infection in these patients. What about a psychosocial priority? Nobody wants to interact tonight. So for me, a priority psychosocial would be fear, anxiety in the patient, and then fear, anxiety in the parents. So remember, we're not just looking at the patient when we're talking about children, we're looking at the parents too. Psychosocial is very important. Absolutely. That's why I bring it up. So when we go through some of the PowerPoints and the different types of cancer, you need to remember that it's psychosocial as well. And then, since we're talking about children, some of their developmental stages. So keep in mind when we talk about some of these cancers, these patients could be in the hospital for months at a time. So, what's their psychosocial and their interaction with their peers in their developmental stages? Some of our cancers occur most often in some of our teenagers. So, what's most important for teenagers? I know the screen's not showing because I was trying to interact with y'all. I'll put it back up in a minute. I'm not doing any slides yet. So, you're not missing anything. Just trying to give an overview. So, when we talk about the developmental stages, you really need to think about what's going on with these patients and what is their think about Erickson's as well. If we're talking about teenagers, friends are important. But remember, these patients are in isolation a lot of times for their own protection. So we're isolating them from their peers and their friends. So keeping that in mind, that's part of thinking and taking into consideration the whole patient when we're caring for them. So, our outcomes, we're going to identify the pathophysiology, etiology, clinical features, diagnostics used to diagnose the different cancers, treatment options, complications, and nursing interventions. And the topics we're going to talk about most are leukemia, neuroblastoma, Wilms tumor, and osteosarcoma, and touch on brain tumors as well. We're going to prioritize care and nursing interventions required to treat clients with these oncological disorders and sometimes emergencies, and then incorporate the pharmacological principles to administer medications to these clients. and then evaluate that care that we've rendered for these clients. So when we talk about oncology, remember most often our treatment is chemotherapy. We also use a lot of corticosteroids and pain medications. So we're not going to delve into the different types of chemo because NCLEX doesn't test on that. Because you have to be chemo certified, you have to go through specific training in order to be able to administer the chemotherapy. In some facilities, you have to be chemo certified to administer methotrexate. And we use methotrexate is a pill, but we use methotrexate, and it is a chemo agent, but we use that for rheumatoid arthritis. So NCLEX doesn't necessarily test on particular medications related to chemotherapy agents, but they do test on what do you need to monitor for any chemotherapy agent. How do you need to take care of a patient who is on a chemotherapy agent? So with that being said, when we talk about chemotherapy, it's just a broad spectrum or a broad term for the different medications. I do list some of the medications, but again, you're not going to have to know those in detail. So, our first cancer that we're going to talk about is leukemia. Most often in children, give me just a second. Sorry about that. I'm staying in an Airbnb right now and somebody rang the doorbell. Um most the most common cancer in children and teens is that leukemia. It is a cancer of the blood and the bone marrow, and 25% of the childhood cancers in the US are classified as acute lymphocytic leukemia. It does affect children ages 1 to 4, but that doesn't exclude the older adults. And about 14% are older children, not necessarily adults. About 14% of our population that develop leukemia is a older teenage child, and they're still considered children. The anatomy of the bone and how those blood cells are made. The bone is made up of that compact bone, remember, it's that spongy bone that contains the red bone marrow. Those compact bones make up the outer layer of the bone, and then the spongy bone is most often found at the ends of those bones, and that's where we get most of our red marrow, and you can see that by the diagram there. The bone marrow is found in the center of most of our bones, in the ends and the centers, and that's where most of our blood cells are. So there are two types of bone marrow, the red and the yellow. And then the red marrow contains those blood cells and those blood stem cells. And that's what makes the blood cells. So when we talk about a stem cell transplant or a bone marrow transplant for some of these patients, especially with leukemia, that's what we're talking about. And that's where it's going. The white blood cells or the platelets are also formed in the bone marrow. So think about all the abnormalities we see in blood work and lab values in the patients that develop leukemia. It's not just the red blood cells, it's also the white blood cells and then the platelets. And then if you know anything about chemotherapy, what does it do? It's going to deplete and decrease the red blood cells, deplete and decrease the white blood cells, and also the platelets as well. So when that happens, our patients are further immunocompromised with the treatment and more prone to infection because of that low white cell count. Platelets, what happens there? They could be more prone to bleeding. And then the red blood cells makes them anemic. So think about what types of symptoms they might present with. So for our pathophysiology of our acute leukemia, the bone marrow makes those blood stem cells, and those are what we call the immature cells. They do become mature over time. So again, if we're talking about a young child, think about how mature these cells are. They're not very mature because it does take time. A blood stem cell may become a myeloid cell or a lymphoid stem cell. And then those myeloid stem cells become one of three blood types, or the myeloblasts, the granulocytes, or the red blood cells and platelets. And then you see with the lymphoid stem cells, they become the lymphocytes, the B lymphocytes, the T lymphocytes, and the natural killer cells. And those are what are made up of our white blood cell counts and also cause some of our immune deficient diseases. Your B lymphocytes and T lymphocytes, particularly with your HIV as well. So lots of damage can be done when these patients have leukemia and a lot of abnormalities in their blood type. Blood work. The etiology and risk factors for the acute lymphocytic leukemia, the blood cell function changes. And that's the main, I guess, want to say focus, or if you just remember that the cause is that these cells are changing. And what changes it? We see acute lymphocytic leukemia in a lot of our Down syndrome patients because it's a risk factor. Fanconi anemia, and then changes in the chromosomes or genes. And it occurs in both males or females. What do you think might be some of the signs and symptoms, kind of understanding what the pathophysiology is? Anybody want to take a guess what we might see as signs and symptoms?
Yeah,
Decrease platelets count,
Yes,
pallor, palpitation, anorexia.
could be. Those could all be true. One of the biggest things and one of the first signs is these patients start complaining of fatigue and weakness. And it's very extreme. So think about if we're talking about 1 to 4 year old kids, what do we expect them to be doing? My great nephew just turned 4 the other day, and that boy was wild. Over the weekend when I went and saw him, all over the place. So for him to be um, tired, fatigued, not running around the house and getting all excited about things, that would tell us that something's wrong. So that's typically what parents see. And then once they start doing blood work and diagnostic testing, then we see all of the low blood cell counts, the anemia. We see sometimes these patients have a fever as well. So it just depends. So remember, when you're thinking about the signs and symptoms, what's normal for that age group? Sometimes these patients have pre-existing infections. Symptoms of your low red blood cells or anemia is going to be fatigue, weakness. These patients have cold intolerance, and a lot of times they want to suck on ice. They can be short of breath depending on how anemic they are and how low their hemoglobin and hematocrit are, which could then lead to dizziness, lightheadedness, and definitely the pale skin. Our signs and symptoms that cause decreased white bloods or contribute to the decreased white blood cells is infections and fevers. So oftentimes these patients come in with unexplained fevers and they can't find an origin for the fever, and that's how they get diagnosed. Low platelet counts put them more at risk at bleeding and excessive bruising. So again, with ages 1 through 4, we need to determine and differentiate whether it's some type of abuse, if it's normal bruising for that age group, or if it is a symptom of those low platelet counts. Oftentimes they'll have some bleeding gums and then frequent nosebleeds. We had a patient that was 3 years old, came into the ER. Actually, I think it was almost like consistently for 3 weeks, like 2 to 3 times a week for nosebleeds. And we were like, okay, the nosebleeds continued, but after the second, I think it was the second time in the same week, we wound up doing testing and sending him to the children's hospital, but he was still having frequent nosebleeds that the mom couldn't stop. So he wound up coming to the closest facility. So we were seeing this child a lot because those nosebleeds continued because he continually had that low platelet count. So remember, our white blood cells are what fights off that infection. So if they're not working or they're decreased, these patients are more prone to infection. Some more signs we might see or they might complain of: bone or joint pain. They might have some swelling in the abdomen and not necessarily fluid collection, but it's more of these cancer cells in the abdomen that are accumulating in their liver or their spleen, because remember, both of those metabolize and filter. So they may see an enlarged spleen or liver, and that can be palpated. Loss of appetite. They may have some swollen lymph nodes. Coughing and difficulty in breathing due to that anemia. Swelling of the face and arms, typically the upper body. And then headaches could lead to seizures and vomiting. They could also develop some skin rashes and then those gum problems because of the continued bleeding as well. We typically see more of the skin rashes with your patients and your kids that have acute myeloid leukemia. So, how do we diagnose it? Well, we got to get a really good medical history, a good physical history, and then we do blood smears. So, they're going to do blood counts and blood smears and our routine blood work, our CBCs, our complete metabolic profiles to get the functioning of their kidneys and their liver. Because if we do a complete metabolic profile, we will get the liver enzymes in there as well. To do a blood smear, they'll take that blood sample and they'll literally smear it across a lab glass slide, and then they'll look at it under a microscope and literally count how many cells, and they'll see abnormally low blood cells on those blood smears. They may do a bone marrow aspiration or a bone marrow biopsy. So those could be painful for the patient. So as a nurse, what are we going to do to combat that, especially if they're a child? If you're doing that to well, I have adult children now, but if one of my kids needed that when they were younger, they definitely would have been sedated or done under conscious sedation. Most often that's what they will do because these kids don't sit still enough either. A lot of times they'll see the blood cells will be blasts in the early cells when they do some of those biopsies. They may need to do a lumbar puncture to see if there's any cells in the spinal fluid. And then if they have swollen lymph nodes, they might need to do a lymph node biopsy. And then they may also do some chromosome testing to see if it's genetic or if there's something that can be passed on. For that bone marrow aspiration, they actually put a hollow needle into the bone with a syringe, and then they suck out and aspirate that liquid bone marrow. So just kind of think about how painful that may be. It's usually done, the biopsy is usually done just after the aspiration. So they'll take a piece of the bone and the marrow and with a slightly larger needle and push it down into the bone. Um, what do you think we need to do after they take that aspiration and that biopsy? What would be the biggest risk for this patient?
Infection.
Well, infection for one, but remember they already have low platelet counts, and we're going into the bone marrow that is what builds up and makes those platelets and red blood cells, right? So bleeding is a really um, big, bad, like I say, complication. So as a nurse, we want to hold pressure. Good job clotting. Absolutely. Yes, this lecture is recorded. Um, but it'll be after it's done and you have to be part of the NASLEX community in order to get it. They then send those bone marrow samples to the lab and they'll test it. Again, like I said, the spinal puncture that may be done after they've made the diagnosis to ensure that it has not spread to that spinal tap or that bone or even the brain, because remember the spinal fluid goes to the brain.
I have a question, Professor.
Sure.
When they do the bone marrow aspiration,
Uh-huh.
is that a risk for the to get fracture on the bone while they're doing it?
To get a fracture?
Yeah,
I
while they're
don't
doing the aspiration.
I've never seen it. I mean, I've participated years ago when I worked in a clinic and in an outpatient surgical center. I don't I would not think that you could fracture it because you're not actually, remember, the bones are going to break and they break due to trauma. So, because of the mechanism of injury, I would not think so. But I would have to look at that.
Okay.
If it is, there might be something else going on because remember, your bones are still pretty, um, for lack of a better word, they are pretty thick and hard. Um,
Mhm.
and they're going right into the marrow. So I would not think, I would have to look that up.
Okay, thank you.
It would be a lot of support as well for the patient and the parents. Because that's pretty traumatic having a bone marrow biopsy.
Yeah,
And then as
special for the
nurse,
kid.
I'm sorry.
Special for the kid.
Especially for the kid,
Yeah.
absolutely. So they more than likely, and I do know for kids they do sedate them. But then what would our care be post sedation? We're gonna have to monitor for what? What do you think we would have to monitor for? What would be our
Anyway,
biggest airway?
mm,
Not necessarily airway, take it one step further. Because we're sedating this
Infection.
child.
the respiratory depressed.
Respiratory.
Yeah.
Yep. So a lot of times these medications that they sedate them with cause respiratory depression. So good monitoring of that respiratory. The heart rate, yes, you do want to monitor the heart rate. However, in children, they will respiratory arrest and they will compensate with their heart rate for quite a while. And then they will kind of poop out. And when they for lack of better words, they'll circle the drain. I say they'll get really sick, but it's really quick, and they go from being sick to almost dying, and we're ready to code them in a matter of a couple of seconds. Whereas adults, we have time because our bodies are bigger and older and more matured on the inside. Our bodies have time to compensate, whereas kids don't. So, treatment for ALL, of course, it's going to be chemotherapy. Um, they do go through stages. There's 3 stages of that chemotherapy, and the entire stages, completing the whole 3 stages, takes 2 or could take 2 to 3 years. The most intense period where they may have the most side effects is within the first few weeks. They will spend at least the first month, if not longer, in the hospital. And if they're doing bone marrow transplants, they're going to stay in the hospital and in isolation, neutropenic isolation, to protect them for sometimes a month as well. There are 3 stages. That induction stage is to achieve or put this patient in what we call remission. And when the patient is in remission, there's no longer no longer leukemia cells found in the body or in the bone marrow samples. So again, these patients are getting more frequent bone marrow samples and aspirations. The normal bone marrow cells are going to return, and the blood counts become more normal and stay normal. So remember, remission is not a cure, but there are no more cells noted. Typically, if the patients remain in remission or no new cells are seen in the first year, then they're considered somewhat. They have a better chance of survival and long term survival. But again, these cells can come back as well. More than 95% of the children that start chemotherapy typically enter remission within the first month of that induction phase. It is a intense phase, and it does require that prolonged hospitalization. So again, what are some things we can do as nurses to help the children adjust when they're in these neutropenic precautions? They want their favorite blanket, their favorite stuffed animal. Are we going to be able to give it to them, or let the mom and dad bring it in?
No, special for
No.
stuffed animals. Yeah.
Yep. Everybody wants to send flowers because little Johnny's in the hospital. Are we going to let the flowers go in?
No,
No,
no flowers.
because
No.
they harbor bacteria, right?
Yep.
People want to send a fruit tray, or those what are they called? Edible arrangements where they got the fruit flowers and stuff and hearts and raw fruit. Do we want that to happen?
No.
No, because of all the bacteria that can be in it, right?
Mm-hmm.
So the consolidations phase or the intensification, hence it's called intensification, right? So this is even more intense than the induction phase. And remember, we just said the induction phase is intense as well, right? So this is where they might add a couple more chemotherapy drugs, combination drugs. They may at this point do a stem cell transplant, depending on what their counts are and how long they've been without new cells. They may get a second round of that intense chemotherapy. And you see, I put some agents up there. Again, NCLEX is not going to test you on the agents themselves. Dexamethasone is a corticosteroid. So you may get a test question on dexamethasone related to something else because we use it for several different things. If these children have increased ICP, definitely they're going to use the dexamethasone as well because that will help decrease the swelling. And we know that if the patient has had a lumbar puncture and there's cells inside the spinal cord, that could be leading to the brain as well. So most often, if they go into that remission phase or no more cells, they typically stay in it throughout the induction and the consolidation phase. And then they go into that maintenance phase where they may or may not give them more medications, or they may just now be on that methotrexate at home, which is a pill, for 3 to 5 years. So a lot of times, depending on the type of cancer, they will give them PO chemotherapy agents for a 3 to 5 year time period after, just to make sure that it doesn't come back. So compliance, we really need to educate mom and dad depending on the age of the child. And remember, this child is now getting to, as they grow, they're going to be older. So we have to help with those developmental stages too, and compliance with these medications. So our biggest nursing intervention is going to be to prevent that infection, manage that fatigue, a high protein diet. There's not necessarily any particular type of diet to give these patients, but remember, protein promotes healing. So we want to give a high protein diet. The type of diet that we do not want to give them, and we kind of talked about that a little earlier, is any raw fruits, vegetables, flowers, anything that can harbor bacteria or cause growth on it. Um, Monitor their vital signs. Definitely emotional support for the client and the parent. Sometimes, as nurses, we have to suggest some of those support groups. There may be support groups for the parents and for the children. And then definitely monitor and prevent or decrease that risk for bleeding. So if they're a teenage boy and they're starting to shave, they need an electric razor. If they're a teenage girl and they're starting to shave their legs, we need to tell them about an electric razor. Definitely good oral care. Increase their fiber and fluids, because constipation is a side effect of many of these medications. Good skincare, especially if they're having radiation, because radiation may be a treatment as well. And then educate on the treatment plan and the intensity of this treatment plan and how long it may or may not take. Being realistic with the parents, of course, that's the physician's job, but we as nurses, the physician's going to tell him, here's the plan, here's what's going on, and he's going to be gone. Who's going to be left to deal with the crying mother or the family? It's going to be us nurses. So if you're going into that oncology field, you really need to be abreast as to what these patients and families are going to have to go through. And then definitely neutropenic cautions to prevent those infections and protect that patient. Does anybody have any question? Limit visitors, absolutely. Limit overcrowdedness too. Yeah, and if they're going out into the public or crowded places, definitely need to tell them to wear a mask. If they're allowed out in the hallway at the hospital after the time period has passed, let them go out into the hallway, but put a mask on them. A lot of your children's hospitals have play areas, and they are infection preventable play areas. I've never worked in a children's hospital. I've never done pediatrics completely. Cared for a lot of pediatric kids in the emergency room um, with cold symptoms. We've diagnosed a lot of patients. I do have a friend that's grandbaby had to have a liver transplant at 8 months old, and nobody in the state of Florida would do that liver transplant. So they had to come up here. The grandma was not able to come up as frequently. So because we were right here by CHOA, the children's hospital, I was involved in a lot of his care. And I was very impressed by what I saw when you went in the playroom and the care and the education that they give, because you don't always see that. So if a child or anybody you know is diagnosed with cancer and it's a child, my recommendation would be go to a cancer center and a children's hospital, because they give the best care, because that's all they do. Any questions? No questions? All right, let's talk about a neuroblastoma. So, neuroblastoma is one of the cancers that starts in the cells that are called the neuroblasts, right? Neuroblastoma, right? Those neuroblasts are those immature nerve cells, and they're found in all of the body because remember, we have nerves everywhere. The most often spot for these neuroblastomas to develop is in the adrenal glands, which sit on top of the kidneys. So these are the glands that make hormones that control a lot of our body functions. Um, Neuroblasts typically are found or travel to the spine, the abdomen, the chest, and the neck. So again, that core of the body. Some require treatments depending on the type and the cells that they identify. They may need surgery, chemotherapy, radiation, a bone marrow transplant, or a combination of all of those before the treatment is completed. So the signs and symptoms are going to depend on which part of the body that these neuroblastomas develop. If they're developing in the abdomen, think about these children are going to have abdominal pain. They may have lumps under their skin, which are the actual cancer cells that are going to be really tender to touch. They may have diarrhea and constipation. So if we take out those lumps, how do we know, right? These patients appear in the emergency room or the doctor's office. They ate too much candy yesterday. They got a stomach ache, right? They're very benign or very common signs and symptoms. The only thing that would be an outlier would be that lump under the skin that's tender to touch, and that requires palpating the abdomen. And how many people actually do that full assessment on their patients? The auscultate, or I'm sorry, the inspect, the auscultate, the palpate. How many of us really do that? And it depends on where it is. If it's develops in the chest, these depending on where in the chest, these patients could have wheezing, difficulty breathing. Some other things that we see with that, again, the chest and up, we see drooping eyelids and varied sizes of pupils. So those pupils may be unequal because, again, we know normally is our pupils are equal, round, and reactive to light. Other areas of the bodies, we may see skin lumps anywhere. These patients may develop back pain. So think about where the kidneys are and the adrenal glands. They may see some weight loss. They may have some fevers, or they get those really big eyes that look like they're out of socket, and or bone pain, especially when they're walking or trying to run. That's when people typically notice that something's wrong and it's gets diagnosed with a neuroblastoma, is because these patients are starting to run and they're either falling or they're not able or they're in severe pain. Some complications, of course, they can metastasize. Unfortunately, these do metastasize pretty quickly. And where are they going to metastasize to? They go to the lymph nodes, the bone marrow, the liver. They can develop in the skin and then the bones themselves. So, really good monitoring some of these signs and symptoms and catching it before it metastasizes is key. They may develop some pressure on the spinal cord because they can grow in that area and then press on the cord, or grow in the bones and press on the cord. A paraneoplastic syndrome is when that cancer has spread and they develop these 4 symptoms, which is the rapid eye movements, difficulty with coordination, abdominal swelling, and then severe diarrhea. These patients definitely need some treatment. And what do you think we treat them with? Chemotherapy. Sometimes surgery. Depending on the stage, these patients can be observed very closely. If it's not as severe to where they need treatment right away. Their signs and symptoms may disappear or change. They may need some surgery. They do surgical to remove it from that part of the body. But again, anytime we open a patient or cut a patient, do surgery on a patient who has any type of cancer, it increases the risk of that cancer then metastasizing. So sometimes they may do chemotherapy or radiation therapy to decrease it and then try to do surgery. High dose chemotherapy and radiation with stem cell rescue, where they actually try to rescue the good cells to then transplant. The iodine 131 MIBG therapy is a particular chemotherapy with iodine. And then targeted therapy is where they may inject the iodine right into the neuroblastoma itself. And then oftentimes they may need some immunotherapy. Most often with the radiation, it's an external where they're on a machine. So, what are some complications of radiation? It doesn't matter what type, it's any type. What do you think some complications might be? Not necessarily loss of hair with radiation, but definitely with chemotherapy. Yes, burning of the skin, absolutely. So definitely doing good skincare would be awesome. What types of NCLEX questions do we expect? Well, all of the answers and the questions that I'm kind of asking you, overall care of the patient. Remember in the beginning, I said their NCLEX is probably not going to test you on the actual chemotherapy agents, but how are you going to take care of this patient? So that's what I'm kind of asking to get you all involved in. What is your care going to involve? What can you do as a nurse to treat the patient or help the patient? You could be asked a psychosocial question related to it. You could be asked any type of question related to what's the complication of radiation therapy. So, what are you going to do to prevent that or to treat it once it comes? Good skincare is basically what you're going to do for that as well. There are some different types of immunotherapy, but again, those are some very specific medications and drugs, and NCLEX isn't really going to teach you on those, or I'm sorry, test you on those. But knowing that immunotherapy could help they may ask a question. What are the best treatments for neuroblastoma? Select all that apply. You may have immunotherapy, targeted therapy, chemotherapy. I can't think of something off the top of my head. Let me think of an incorrect answer. Do nothing and I can't think of something off the top of my head. It's been a long day. But knowing that immunotherapy is one chemotherapy, they're not going to ask you what chemotherapy agents or what immunotherapy agents, but as a whole, the whole classification. Um, any questions on your neuroblastomas? And we're going to do questions at the end of this. No live immunizations. Very good. I talk about that in a few minutes as well. Wear a lead apron. Who to wear the lead apron? The nurse? What about the child? Because can radiation cause sterility? Yes, it can. Absolutely. So we want to put that lead apron over the male or female's genital area. No cream before radiation. Absolutely. Because what happens when somebody puts cream on. It can burn them even more. So we want to do that good skincare, but not on the day of radiation. We may be doing good skincare the day after. We do want them to wash with soap and water, but a mild soap. Do you all know, get the hazmat team to clean urine if it spills? If they've had chemo or radiation, yes, you are correct. But again, that's specific. I don't think NCLEX would test you so much on that because it's also specific to which chemotherapy agent that they're using. Do y'all know which brand of soap is the most mild? To educate your patients? It's like a brand. So Aveeno is it's made with oatmeal, so that Aveeno soap and products are made with oatmeal. Those are really good. Dove is a very mild soap. You want them to avoid any scented soaps. Irish Spring is out there. Ivory is scented. It would have to be unscented. Irish Spring is out there, and it's full of a lot of fragrance and a lot of chemicals. So it depends on where you live and what your culture believes in as well. So that may play a part in it as well. But educating and getting to know your patients and getting that good history will help you determine to tell them what to use. The best laundry detergent is your all free and clear, which means it has no dyes, no perfumes, none of that. Tide and Gain are the worst ones because they have a lot of fragrances in them, and the better they smell, the worse they are for you. Dial Gold, I don't know about Dial. You want a very mild soap. Johnson & Johnson would be fine because we actually children who have blocked tear ducts and their eyes get crusty, or if they have conjunctivitis, we actually tell them to get Johnson & Johnson baby soap and wipe the eyes. And I saw in the store the other day, I was picking stuff up for my niece for the boys, and they have wipes, Johnson & Johnson baby wipes for their eyes. Yes, good point. Wash separately from house laundry, all of that patient's clothes. For two reasons. We want to keep everything separate to prevent that patient from getting sicker. And also, we don't want to cross contaminate with our clothes to get into them. So let's talk about a Wilms tumor, which is a nephroblastoma. It is a rare kidney cancer. It is the most common of the kidney cancers in children, and we typically see it in children 3 to 4 years old. It is less common in children greater than 5, and it's mostly unilateral. So we only typically see it in one kidney. And then the diagnosis and the prognosis have improved over the years. They've come up with a lot better treatments due to all the trials and the clinical trials that they can do for some of these. So, what are our symptoms? Well, they're going to vary. We may see abdominal swelling again. We may see pain, a fever, hematuria in the urine, low RBCs that indicate anemia. So they may present with those signs and symptoms of anemia. And then because it's a renal or kidney, we may see hypertension. Remember that our kidneys help control blood pressure as well. So some of the risk factors: African American or Black descent, a family history of another child having it or the parent having it when they were a child. Some of our pre-existing conditions at birth is that I can never say it, aniridia, which is the colored portion of their eye, the iris, is only forms a part of it or doesn't form at all. Hemihypertrophy, um, Wegar syndrome, Dennis-Strass syndrome, or the Beckwith-Weidman syndrome. I don't typically think NCLEX would test you on these, because those are very specific and they diagnose those with genetic testing. So that's not common, right? And also it's very expensive. So they might test you on pre-existing conditions that could contribute or be risk factors to Wilms tumor, may be pre-existing conditions and your syndromes, because you see all of those engine syndrome. The Dennis-Strass syndrome is kidney disease and male pseudo malformation. And boys, their genitals aren't clearly male, so they may have a male and a female they can't completely identify. They may have part of a vagina and one testicle, you see it more in males where the males get the female parts. The Beckwith-Weidman syndrome, these children tend to be much larger than somebody their same age. They're known as macrosomia, and their organs in their stomach are much bigger. So again, remember, in our abdominal area or the core is the kidneys. So the kidneys are going to be large. These patients may have large tongues, large internal organs. So we may see cardiomegaly on a chest X-ray if we're looking at their heart, and they're just not formed right. So diagnosis for these Wilms tumor, a good physical exam, palpating the liver and the spleen to palpate for enlargement, getting a good history if they're complaining of abdominal pain. And then we diagnose, they may have blood in their urine. So we're going to diagnose that by getting a urine sample. We do blood work, kidney function. An ultrasound is going to show those tumors on those adrenals or near the kidneys. A CAT scan and an MRI are going to show even more those, but we start off with the the least invasive to the most invasive. And a lot of times an ultrasound can diagnose those, because we really don't want kids to be exposed to CAT scan machines or MRIs unless they absolutely have to. Children should be sent to a children's hospital for CAT scan because of the less radiation, and not an adult CAT scan machine. And then your chest X-ray is going to show that cardiomegaly, that enlarged heart. So remember, we said we stage these, and the prognosis is according to the staging. So stage 1 is it's just found in one kidney and the surgery can remove it. They can have a nephrectomy if need be. Stage 2, it's in the kidney and then invaded the fat or the blood vessels. Excuse me. Surgery can still remove those and those areas. Again, remember, the higher we go in our stages when we're talking about cancer, the poorer the prognosis is. So our stage 3 is our kidney, our lymph nodes, and then it could spread into the mesenteric area of the abdomen. What they'll do in surgery can do it, but they also can remove it, and they can do the stages, or they'll remove the lymph nodes until they get at least 2 cleared lymph nodes in that area. The other thing is it depends on if it's already metastasized at stage 3, which it can because it's going outside of the region. They may do chemotherapy or radiation first and then surgery to it to remove it. If it's gone outside the kidney, stage 4, it's metastasized to the lungs, the liver, the bones, or the brain. So again, their prognosis is going to be poorer. They're definitely going to need high dose chemotherapy and or radiation. And then stage 5 means it's gone to both kidneys. And then they stage each kidney individually. So if we got stage 5 and now we're staging the 2 kidneys and we got stage 5 in both the kidneys, their chance of survival is very, very poor. So the treatment, again, is surgery, chemotherapy, or radiation, depending on what stage it is and how far it's progressed. The surgery, they can do a partial nephrectomy, a total nephrectomy, and then go from there. They may need a kidney transplant depending on how bad it is and if it's completely invaded the kidney. So nursing interventions can focus on remember to support and focusing on supporting the client and the parent. Monitor this kid's energy level. It depending on the age of the child, include them in the plan of care. Even if they're 4 years old, they want a say in what they want to do because they're not going to be compliant. Give them options in between, or give them 2 choices of the options so that they can still feel in control. Increase fluid intake, monitor their output. Again, protein-rich foods because we want to promote healing, prevent infection, and then manage what other symptoms they may have either to the chemotherapy or the radiation. Our goal is to preserve whatever kidney function we can. Definitely encouraging good mouth care. Again, it depends on what kind of symptoms they have or side effects they have to the chemo. Good mouth care, anytime we talk about chemo, it's good mouth care. Definitely check with the provider because, again, they're a child and they need immunizations. What immunizations can they get or not have? Talk to if there's other kids in the house. Talk to the other kids and get their input in the care as well. Definitely, if they've had metastasis, then definitely monitor for the worsening or wherever it has metastasized to. We need good assessments of. Any questions? All right, let's talk about osteosarcoma. That is bone cancer. It is very rare. It affects about 400 children less than under 20 years old in the U.S. Typically, we see it between 10 and 20 when they start to do those sports and when they start to run. And it typically occurs when these patients are having their growth spurts. That's how they identify it. They develop this intense pain in their bones or they're unable to do sports or participate or run or run. Unfortunately, it is more prevalent in boys, and I don't know what it has to do with, but we diagnose it a lot more in boys easier because they're always out running. Signs and symptoms are going to have pain, stiffness, tenderness at that tumor site. That pain does get progressively worse. Depending on the size of the tumor, they may have mild pain and it just may be something that gets blown off, but then it gets worse. A lot of times it does awaken these kids at night, which is completely abnormal for a 10 to 20-year-old, right? Swelling, there may be a mass near the affected bone, and then difficulty walking or limping. It's just too hard to walk, and they get very weak bones, and this could lead to fractures. When we were talking about bone marrow aspirations and those causing fractures, but this can lead to fractures because the bones do get very weak in your osteosarcomas. And then it can develop or be involved in the spinal cord, because again, remember, what's the spinal cord? A whole bunch of bones that protect us and maintain our alignment as well, or lack of alignment. We diagnose it with an X-ray, MRI, CT. Your 3D imaging is a technology where they use three-dimensional models in X-rays and in CT scanning. They may do a PET scan and they look for what we call hot spots, where it'll literally show up red, and that means those are cancer spots. Or they may need to do a needle biopsy and then send that for analysis to do a biopsy of that area or that tumor. We treat it again with chemo, radiation, or surgery. Our surgeries might be an actual joint replacement. They may use a cadaver bone graft, may use free vascularized fibrillar grafting, which is in conjunction with that cadaver bone graft, or they may have to amputate part of that area. So again, think about these kids, they're 10 to 20. What kind of psychosocial things are going on if they have to have an amputation? That can be very difficult. And then what do they need to be taught, and how can they overcome this? So our nursing interventions for our osteosarcoma is going to be the same as with all our cancers. Prevent infection, manage their symptoms, manage their pain, keep them free of infection. A lot of teaching. If they're getting chemo, we want to do good mouth care, oral care, because remember, a lot of the chemotherapies can cause thrush. Brain tumors are going to be the same. They just form in the brain, any part of the brain, depending on where it is and how fast they grow, but we're managing them the same way. Does anybody have any questions on any of the information? Are you ready to do some practice questions? Thank you for good stuff. So somebody asked, what is the main priority for post osteosarcoma, after surgery, or for what do you mean by post osteosarcoma? Post diagnosis, post surgery. So what do you think would be the main priority? Pain or infection? Because that's what you're asking. I'm throwing it back at you. I want you to critically think about that. Because you could get a test question on NCLEX about that.
I would say infection.
Infection, yep. So I just had this conversation today in the skills lab with my students. Everybody wants to go to pain. Students always want to treat the pain, right? But I've been in nurse 30, it'll be 38 years this year. I can't believe I'm saying that because I don't feel that old. But I've never seen anybody die of pain. One of my students was like, well, chest pain. Well, no, they don't die of the chest pain. They die of the clot that's causing the chest pain. So even though pain is important, yes, it is expected. it's important to manage it, but that's just a symptom of something else and probably something worse going on. I'm sorry, I was reading the chat. It is a symptom of something worse going on. Nobody's ever died of a fever, which is also a symptom of something worse going on. What they die of is infection, sepsis, or any of the things that the fever causes. So those are just symptoms. So when we're talking about priority and you're answering an NCLEX style question related to pain or infection or something else, or it's just a priority question. Pain and teaching are going to be on the bottom of that list unless they're asking what is the most important aspect of treating this pain, or what is the best medication to treat this pain. So if the content of the question is completely related to pain, then yes, that's going to be your focus. But if the content of your question, kind of like what you asked me, what is the priority post-op of osteosarcoma, or what do we want to prevent or treat, it's going to be that infection and not necessarily the pain. Because patients come into the ER all the time with a heart attack and they're in severe pain, but if their blood pressure is very low, we can't give them the nitro or the morphine that will help relieve that and alleviate that pain because they're too unstable. So once we kind of fix the problem by taking them to the cath lab, their pain goes away. Does that make sense? Hemorrhage could be a priority, but it's not a huge risk. Now, if they're having a kidney transplant, that might be a bigger risk. But again, any surgery can cause hemorrhage, but I hope that's identified before they come out and they're on the floor. It depends on what the question is asking and wanting to know. Most often, it's going to be infection. Nursing care management of patients on radiation and chemotherapy. So, again, what do you think? We kind of talked about both of those. Chemotherapy causes all kinds of symptoms. We said good oral care because it can cause thrush. Radiation, good skin care. Avoid using lotions on the day that they're having radiation. Good assessment of both of those. And then they both can cause nausea and vomiting and constipation. So caring for those and treating those. Food, fluids, and fiber for constipation. And nausea, a lot of times they have medications. Ondansetron, Zofran, was developed in the early 90s for chemotherapy induced or chemotherapy caused nausea and vomiting. So we also want to prevent dehydration. So what does that look like when I say prevent dehydration? What are your nursing actions gonna entail that's gonna help prevent dehydration? Anybody?
Fluid replacement.
I'm sorry.
Fluid replacement.
Fluid
IV
replacement. Yeah.
fluids.
Good assessment, right? A good skin assessment, a good skin turgor assessment, assessing their mucous membranes, right? All of those things that you're going to do. If they're nauseous, we may need to sit there and give them a teaspoonful of fluids every 10, 15 minutes. It's an overall. Any other questions? Oral fluids, eyes and nose, rehydrate. Yep, absolutely. So with monitoring eyes and nose, you're not incorrect with that. But here's a test taking strategy. If it was, if it said provide oral fluids, monitor I's and O's, and rehydrate, we're probably going to do rehydrate. Monitor I's and O's is not going to fix a patient right now, right? Um, so really kind of think of the wording of that. If it's a priority question, monitoring I's and O's is not going to be your priority answer because that can't fix the patient and that takes a little while, right? If he's not drinking right now, yes, we are going to do it. And remember, our priority questions are all correct answer choices. Somebody put in here, pain can kill sickle cell patients. Well, I disagree with that. It's not the pain, it's the sickle cell process and what's going on. What happens with a patient who has sickle cell? Their red blood cells are sickled. So, and that causes the pain. But what could kill them is that chest where those sickled cells become clotted in their arteries in their chest or in their lungs, where they wind up with a pulmonary embolism. So again, it's not really the pain that kills them, it or causes their demise. It's the blood clot that causes the pain. But IV pain meds and O2 would be the priority. So again, you are correct, but O2 would be your priority over your IV pain medicines. You want to get O2 on them because, again, remember, our red blood cells in our sickle cell patients carry oxygen. So they're in pain because that area is not getting oxygen, and those sickled cells are blocking the blood flow. So by giving them fluids and oxygen, you're trying to get those cells to move. Pain again is still just a symptom of that sickle cell. It is a priority, but getting them oxygen and managing. Remember, airway, breathing, circulation, and disability. Your ABCD, your airway, your breathing, your circulation, and then your disability relates to your neuro. Pain doesn't fall on those 4 areas, because again, that pain is the symptom of something else that we have to fix. Does that make sense? Oxygen is the priority then. Yes.
Yes. But
Oxygen is
I was thinking you would give, if their O2 is, it depends on how the question is asked. Because if the oxygen level is sitting at a 98, I was thinking, well, I was taught to give the IV, then the oxygen. Because
so
the blood is clotting, so you have to loosen it up. But I could be wrong.
well, the pain medication is not going to loosen it. The
No,
pain medication is not going to loosen the clot.
the IV, you would give the fluids to loosen up because the oxygen is carried through the blood cell. So with the sickle
Right.
cell,
Right.
if it's clotting up and they're in a crisis, the IV is what I was told to give first if you had a priority question and they're sitting at a 98. Now, if they're sitting, below a 90, then of course you want to go with the ABC.
Okay.
But
So
NCLEX is tricky.
well, it is kind of tricky, but there's no absolute. So you're absolutely correct. You said if the O2 sat was 90, the fluids and the oxygen are not going to break up those sickled cells. They are going to kind of help them move, but um the only thing, if they're clotting an area, and I don't know if you were on when we talked about sickle cell, if those sickled cells become clotted in an area and block off the blood flow, it's a perfusion problem. That's lack of perfusion, which can be circulation and breathing. So it really depends on what the question wants to know. Somebody put in here, in acute cases, pain is priority. Well, I'm not going to dispute it back and forth. My point of saying that pain is not typically a priority, it depends on the question. It depends on what the question is asking, and it depends on, all I'm saying is pain is a symptom of something else, right? So pain has never killed anybody. Even your sickle cell patients, pain does not kill them. What kills them is those sickled cells that get clotted and cause a pulmonary embolism. Again, it does. It depends on what the question is asking and how it's worded. Unfortunately, in nursing, there is no, just because I answered this question like this, that's going to be the answer for any of them, right? Also, remember, pain is expected on sickle cell patients too. Perfusion is the priority. Absolutely. Absolutely. So that is what I'm trying to convey. I guess I wasn't doing it. I'm not insensitive. I treat pain, absolutely. But again, it depends on the patient's situation and presentation. Yeah, ABC is the key. So my what I want to stress is that pain and a fever are symptoms of something else going on. So we have to figure out, or the doctors have to figure out with our help and our assessment, what is going on with this patient. Does that make sense? Would you give pain meds first for a sickle cell crisis? Again, it depends on what the question says. Like she was saying, if the pulse ox is 98% and the patient has a decent blood pressure, then you could give pain. But if the pulse ox is 92, I'm going to put the oxygen on because that is a breathing issue. I need to treat that breathing issue first, then the pain. So it's not an all or nothing. Pain meds would drop O2 lower, absolutely. And it will drop the blood pressure lower too. So Thursday, I'm doing the pharmacology lecture on analgesic medications. So we'll talk a lot about that on Thursday too, if you're on. So let's do some of our questions. A nurse on the oncology unit is caring for a child diagnosed with acute lymphoblastic leukemia. Which of the following interventions should be implemented to reduce the risk of bleeding? So it's a select all that apply question, and you can see there's more than 4 answer choices. So if y'all kind of talk to me while we're doing the questions, I don't have to keep going back and forth between the screens.
C and E, Professor. C and E is the answer.
C and D or C and E?
E as in egg.
C
E
and
as in
E.
egg? Yes. So C as in
Yes.
cat and E as in egg. So remember, your children with acute lymphocytic leukemia have already a high risk of prolonged bleeding because of that thrombocytopenia. So if we're applying pressure for an extended period of time, that's going to prevent excessive blood loss when after we give that injection. We don't want this patient to blow his nose very hard because remember, Our capillaries in our nose are very fragile and they bleed easily. And especially kids, remember, kids bleed, kids tend to have nosebleeds a lot. So the answer is C and E. Now, why do we not want to use a rectal route for a temperature?
Increases the risk of bleeding.
It sure does. Yep. So does that ibuprofen, and so does dental flossing. We want the child to brush their teeth and provide good oral care, but we don't want dental flossing as because remember that's in the gums, and the gums bleed too, especially in our patients who are develop or who have thrombocytopenia. So, a nurse is reviewing the laboratory results of a child with acute lymphoblastic leukemia receiving chemotherapy. That's the lab work that's there. So, if I was taking this test, I would look at that lab and decide what is abnormal. What do you think about the hemoglobin?
It's low.
It's low. What about the hematocrit?
It's low.
It's low. What about the WBCs?
Is low as well.
The
Yeah.
WB, it's within.
And what about the platelets?
The platelet is
It's
low.
low.
Yep. So all of them are low. So which one is my priority? Which one am I most concerned about?
Bleeding.
You need to monitor for bleeding.
Yep. Because that platelet count is the lowest, right? Or the most severely low, or however you want to word that. Your WBCs, they're borderline. They're low normal, right? Your hemoglobin and hematocrit, it's not way out of whack. It's not it's not normal, but we kind of expect that. And when we look at the ratio, remember your hematocrit should be 3 times what your hemoglobin is. So that is correct. But our platelets could cause the worst damage to this patient. Yep. We do need neutropenic precautions, but again, that's not going to take priority over that bleeding precautions.
Right.
The nurses in an outpatient care facility has received the following telephone messages from the parents of a pediatric client previously seen at the facility. The nurse should first telephone the parent of the client with which which condition.
The D?
D, absolutely. Because that fever is a sign of something else going on. And he's already diagnosed with acute lymphocytic leukemia. So we know he's more prone to infection. And that fever is a sign of infection.
Yeah.
The patient who had with diabetes mellitus, who had a hypoglycemia episode last evening, I'm hoping he's resolved and they fixed it last night. That's not an emergency. Autism spectrum disorder who reports generalized muscle aches and malaise. Well, it is discomfort and it could be the sign of an illness, but I need more information about that autism spectrum disorder, right? And these patients tend to have aches and pains as well. And then the juvenile arthritis reports swelling in the right knee and limping. Again, that's kind of an expected thing. He does need to be seen, but none of those need to be seen before the patient who has the fever with ALL. A nurse is assessing a client with acute lymphocytic leukemia. Which of the following findings would be consistent with ALL?
Headache?
Yeah. Why do you say headache? You're correct.
It might be a sign of hypoxia, and with leukemia, we're looking at reduced platelet count and all that, which is related to transportation of oxygen to the brain.
Okay.
So that's my line of thinking right now.
That's a good one. But remember, these patients can have CNS involvement, right? It may have spread to the brain. Nobody's polyuria, while it's not typical of ALL, it's probably associated with something else. They don't have increased platelet counts, they have decreased, and they don't have weight gain, they have weight loss or anorexia, right? A nurse is educating a student, a nurse is educating student nurses on nephroblastoma. Which of the following
After the
students?
bird. That's our chicken. Lotala.
I can't.
Lotala.
Can you all mute yourself, please? If you're not asking questions.
Okay, mmecha m ga-akọlụgharị ya ịnọ na online ya tutor.
Please stop unmuting yourself if you're talking to somebody else. I just muted everybody. Unmute yourself only if you're going to answer, please. There's a lot of you for me to go through to mute. Okay. All right. A nurse is educating student nurses on nephroblastoma. Which of the following student nurses' statements require follow-up? This is a select all that apply, but we're also looking for what type of answer choice.
Wrong.
A wrong answer choice, absolutely.
B. It's B.
That's one of them. It's a select all that apply.
A.
E.
D.
E.
So remember, a nephroblastoma is on the adrenal glands, which is by the kidneys. So it's most often confined to one kidney. Daily palpation of the abdomen is essential to monitor the size of the mass. So that is incorrect. That is a correct answer choice for this question, because the more we palpate, the more of a chance we have of rupturing that tumor. That mass is often soft and tender. That is incorrect. They are typically hard. And remember, your Wilms tumor are firm and non-tender.
B, C, A.
B, C, and what?
Well, so management includes surgical resection of the tumor. So I thought it could be surgical or
it's B.
Chemo.
For this question,
It's B and
B
C.
and C are your answer
B and
choice.
C.
Right.
We're looking for import.
Management includes surgical resection of the tumor is a correct statement. And these patients can have hypertension as one of their clinical manifestations. So this question wants to know which are incorrect.
Correct. Yeah.
Yeah, so it's B and C. A nurse is caring for a client with suspected Wilms tumor. Which of the following is the initial, so which one is first, diagnostic test for this condition?
B.
B.
It's an ultrasound, right?
Yeah.
B, ultrasound, because again, we want to do the least invasive to the most invasive. So ultrasound is just looking at sound waves. That doesn't cause the patient any radiation, any harm. Your CT of the abdomen is going to require contrast, and your MRI is going to give that gallium and that magnetic stuff. Your chest x-ray is not going to diagnose your Wilms tumor, but it can help diagnose that cardiomegaly, that enlarged heart. So you see why that is there, and the ultrasound is the correct answer. A nurse is caring for a toddler with neuroblastoma. Which of the following, oops, I forgot the F, findings should the nurse anticipate? Again, it's select all that apply.
A, B, E.
A, B, E, absolutely. These tumors are irregular abdominal masses. They do cross the midline because remember, they could be in the kidneys and the spleen, which is on both sides of the abdomen, and they have failure to thrive. Most common signs of these tumors is their loss of appetite, and they're not really moving. Remember, they're on the adrenal glands, right? So think about what those were. It doesn't cause hypotension, it can cause hypertension. And soft and tender is the opposite of that irregular abdominal mass. So the answer is A, B, and E. A nurse is educating a group of nurses on osteosarcoma. Which of the following statements should be included in the teaching? Select all that apply.
A, B, C.
A, B, what?
C.
Okay, so let's talk about these. A, osteosarcoma most commonly affects the femur. Yes, that is correct. Remember, we said lower extremities, and these patients tend to have a lot of walking difficulties. Pain at the tumor site is usually intermittent and only occurs with activity. That's incorrect. When does it mostly occur?
At rest.
At night and at rest, yes. So we have A palpable mass may be present at the infected site. An affected site would be the site of pain. So C is correct. Osteosarcoma is the most common primary bone cancer in children and adolescents. So think about what age group did we say this typically occurs in?
20.
10 to 20 years.
10 to 20. So that's a correct statement. And then radiation therapy is the first line treatment for osteosarcoma. Radiation is not. It's chemotherapy, right? So our correct answers are A, C, and D. A nurse is caring for a 6-year-old child with a brain tumor who is 30 minutes post craniotomy and notices colorless drainage on the surgical dressing. Which of the following actions would be most appropriate? So, should we have colorless drainage on the surgical dressing?
No.
No.
Nope. What is colorless drainage representative of?
CSF.
Cerebral
CSF
CSF
leaking.
fluid. Yep. So what are we going to do?
Notify the provider.
Notify doctor.
Notify the doctor. Why are we not going to put him in Trendelenburg?
Because it's the first dressing after surgery. It
Yeah.
will increase intracranial pressure.
Yeah, it's
It'll
gonna
increase
increase.
several reasons, right?
Mhm.
It'll increase the intracranial pressure. It can increase infection because it's pushing everything towards those meninges, and it will increase that intracranial pressure and could cause meningitis. And we definitely need to contact the physician. Reinforce the dressing. Well, we can do that, but not before we contact the physician. Mark the drainage areas and reassess in 30 minutes. Well, I call that a do nothing answer choice, right? Yes, we're going to mark the drainage edges, and yes, we are probably going to reassess in 30 minutes, but before that 30 minutes, we're probably going to reassess in 5 minutes, right? We're going to call the doctor, we're going to mark the drainage, we're going to reinforce that dressing. We're definitely not going to put him in Trendelenburg, and we're going to reassess in like 5 minutes, right? And
What
a
if
nurse, I'm sorry.
I was just asking a question pertaining to the colorless dressing? You were saying something that colorless drainage is what?
I didn't hear you. You were kind of muffled.
Were you
It's
saying that
CSF.
is
Cerebral
CFF?
fluid.
Okay. I just want to be sure because I didn't hear properly.
Colorless drainage is CSF fluid.
Okay.
A nurse is caring for a child 15 minutes post left-sided craniotomy. Which of the interventions should the nurse include in the plan of care? So it's left-sided. Do we want to put them on the side that had surgery?
No.
No. So A is incorrect. Do we want to put them in a quiet room?
Yes.
Yes.
Yes. Why do we want to put
Yes.
them in a quiet room?
Reduce stimuli.
Reduce stimuli.
Yep. Limit stimuli so that their intracranial pressure doesn't go up, right? So B is
Yes.
correct. Administer analgesics as prescribed.
Yes, sir.
Yeah.
Yes.
Yeah.
Yep. Again, pain can increase the ICP, right?
Mm-hmm.
And then
Yeah.
monitor the vital signs hourly.
No.
Is hourly enough?
Yeah.
No,
No.
less than that.
Like
Not
15 minutes.
15 minutes.
every
Every
15
15
minutes.
minutes.
And then E, monitor for colorless drainage on the dressing.
Yes.
Correct.
Yes.
Yes.
So it's B, C, and E. So we're going to do a case study. This is a question related to case studies. And NCLEX has started adding a lot of these case studies where they'll give you a lot of information and you'll answer a series of 6 questions that all go through the nursing process. So each question is asking you some part of the nursing process related to this case scenario. So a nurse in the emergency department is caring for a 5-year-old male client. At 8 a.m., the nurse's notes state, client brought by caregivers with complaints of fatigue, pale appearance, and low-grade fever for the past 3 days. The caregivers report that the child has been less active and has developed new bruises and petechiae on the arms and legs. They also mentioned decreased appetite and episodes of nosebleeds over the past week. So, if I was taking NCLEX, I would be asking myself, what do I think this is? Complaints of fatigue. He's 5 years old. Do we expect that? No.
No.
He's pale appearance. That's a negative too, right?
Right.
He has a
Mhm.
low grade temp. That's abnormal. He's less active. That's abnormal for a 5-year-old, right? And has developed new bruises and petechiae. Remember, petechiae is a sign of low platelets and
Mhm.
could be liver disorder. and bleeding disorders, right?
Mhm.
He's had no appetite and he's had frequent nosebleeds. Uh-oh. Am I concerned?
Very.
Yes.
Yes. So, physical exam at that time, he's pale, lying in bed, no cyanosis or edema. Anything concern me there?
Mm-hmm.
What?
Paleness.
Pale.
Pale and lying in bed. He's 5
Yes.
years old. What 5-year-old is going to sit in the bed, right? None that I know of. They're going to be wanting touching everything in that room, right?
Mm-hmm.
Right.
Yes.
Lethargic but arousable to verbal stimuli. Anything concern me?
Lethargic.
Lethargic.
Lethargic,
Lethargic.
right? Moves all extremities spontaneously and no focal deficit. Are we good?
Yes.
Yes.
We're good there,
Yes.
right? Pale conjunctiva. Do we expect that?
No.
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 So he's got pale skin, he's
No.
lethargic, and pale conjunctiva. So what are we thinking?
Either
Low counts. Low
dehydration
counts.
Pale.
or
Low
Anemia.
hemoglobin.
He's got anemia probably.
Mm.
His oral pharynx is clear with some bleeding noted on the gum margins.
Mm-hmm.
Mild
Bleeding.
nasal crusting without active bleeding and no lymphadenopathy. Vesicular breath sounds auscultated bilaterally, so we're good. S1, S2 heard with no murmurs.
They're
We're good. Pulses 2+ in all extremities. Is that good for his age?
Yes.
Yes.
Yeah. His abdomen is soft, non-tender, and non-distended, so we're good, right?
Mm-hmm.
Liver palpable 2 centimeters below the right costal margin, and the spleen is palpable 3 centimeters below the left costal margin. We good with that?
Good.
Yes.
That's all normal, right?
Yep.
Mm-hmm.
Petechiae noted on the upper arms and legs. That's not
abnormal.
normal.
Petechia. Not good.
Not good, right? Multiple bruises of varying stages of healing over lower extremities.
Mm-hmm. Not good.
Not good.
Not good, right? But they are healing. So, and then no rash. So that's good. His temperature is 100.6. Blood pressure is 92/54. Heart rate is 126. Respiratory rate is 24. And SpO2 is 96 on room air. So, what are we concerned about there?
The blood pressure,
Pressure is low.
heart rate.
He's
We are
5
concerned about
years
the
old.
temperature.
He's
Heart
5
rate
years old.
is high.
Temperature.
So the temperature,
Pressure
blood
is
pressure is pretty normal because he's
Normal.
5 years old.
Yeah.
okay.
What about that heart rate?
The
Severe.
heart
High.
Normal.
is normal. That
Three-
should be 110 to
120 to 110
Yep.
to
How
160.
about his respiratory rate?
Yeah, the respiratory rate is
Yep. It's normal. And what about his SpO2?
that's
Normal.
good.
It's normal.
It's not
It's
bad.
normal.
Okay, so medical history, he's diagnosed with ALL 6 months ago, currently on maintenance phase of chemotherapy. His last session was 2 weeks ago. Immunizations are up to date prior to chemotherapy, and his current weight is 38.5 or 17.5 kilograms. So, which of the following findings require follow up? So, we talked about this, right? The lethargy, the paleness, the lying in bed and not really moving around, the pale conjunctiva, the mild bleeding or the blood noted on the gums. Abdomen was good, and then that petechiae, right? So, because this is a PowerPoint, I can't highlight or have you highlight. So in NCLEX, you would hit the highlight and you would click on it and you would highlight what you think is abnormal. The nurse reviews the client's medical record. For each potential provider's order, And then you would click on these if you thought it was indicated, non-indicated, or contraindicated to specify, again, whether it's indicated, not indicated, or contraindicated. Would we administer intramuscular diclofenac? Is it not indicated or contraindicated?
Contraindicated.
Contraindicated. Why?
Contraindicated.
Well, there's two reasons why,
That's a
right?
muscle relax.
It's
And he's
muscle,
like,
and
Muscle
it's
bleeding.
and what kind of medication is diclofenac?
Non-steroidal
It's for arthritis.
inflammatory.
Yes, so it's contraindicated because it's
muscle relax.
intramuscular and it's a non-steroidal, right?
Mhm.
Intravenous naltrexone.
Indicated.
Not it. Well,
It's
contraindicated because he's 5. You want to do it less invasive.
We wanted, well,
Well, you can give him an antibiotic,
but is it contraindicated, or do we just want to give it to him the
it'll be
best route?
contra.
It's
It's
not
not indicated.
contraindicated.
It's not.
It's
No.
not
Not
indicated.
indicated.
So I'm ruling out. So it's either indicated or not indicated.
Not indicated.
Why is it not indicated?
it should be
Because he don't have signs of an infection.
No, it does
Well,
have it.
he-
No,
he
it does.
does.
The temperature is high.
Yes.
It's
his
100.
Temperature is high. The
Yes.
temperature is 100 and a little over 100.
It's
So
a little
the
over
IV.
100,
Yeah.
but he has
It's a-
an underlying immunocompromised condition, and he had chemotherapy 2 weeks
Oh,
ago.
right. Yeah. Okay.
So it's indicated.
Right.
Yeah.
okay.
Blood typing and cross match.
Indicated.
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 Initiate airborne precautions.
Not
Not indicated.
Not indicated.
Not
Initiate
indicated.
initiate neutropenic precautions.
Indicated.
Indicated.
Indicated. Yep. So do we all see the difference between those?
Yes.
Yes.
Okay. So let's practice. Physician's order is at 8:30. He writes, administer acetaminophen 180 milligrams PO every 6 hours PRN.
Mhm.
Administer IV fluids D5 half normal saline at 50 mLs an hour. Obtain blood samples for CBC, BUN, and electrolytes. Administer that ceftriaxone IV every 12 hours. Type in cross-match blood for possible transfusion. Initiate neutropenic precautions and monitor for signs of infection or bleeding. The nurse reviews the provider's orders. Which of the following orders should the nurse implement first?
D.
D. We have to-
Yep.
D.
D. Implement the neutropenic precautions, right?
Yep.
Because he's already immunocompromised with the ALL. He's on chemotherapy and he's got signs of infection. So we definitely need to get those in initiate those precautions. What would you do next?
IV fluid.
B.
IV
Resuscitation.
fluids. Yep.
Fluid.
And what would you do after that?
You
We'll do the
C.
you would do
cross the blood
you would
groupings.
do the blood cross and type match.
You do A first
No.
and then C.
C.
Ceftriaxone.
Administer
Yes, you would
IV
start those
antibiotics.
antibiotics first
First.
because what's going to fix that infection?
Mhm.
What's going to fix that infection is those fluids and that ceftriaxone.
Mm.
That's going to fix that infection. The blood typing isn't going to do anything for his main problem, right?
Mm.
So if you were going to do the answer to this question is D, but if you were going to do it in order, it would be D,
D,
B, A, and
C.
C. So here's your lab work. Anything abnormal?
Yes.
In your CBC, what concerns you the most?
WBC.
WBC.
It's low.
See the hemoglobin is low as well.
Platelet as well.
WBC is low.
Okay,
Hemoglobin.
they're all abnormal, but
Platelet
which
is
one
low.
concerns you the most?
Hemoglobin. Oh no.
The
Is
platelets.
it hemoglobin?
Platelet.
The
Michelle,
platelet.
Platelet.
The platelets should concern you most, okay?
Mhm.
Because of
And
that
white
risk, for bleeding. And then I would be concerned about that WBC.
because of infection.
Yep. And then I would be concerned about that hemoglobin, I would probably be concerned about that that absolute neutrophil count, and then the hemoglobin. Look at his metabolic profile. What is abnormal that concerns you the most?
No.
Everything's normal except that BUN.
BUN, yeah.
Yep. Yep. So the nurse is educating student nurses on vaccines that can be safely administered to the client. Which of the following vaccines should be included in the teaching? So again, it's a select all that apply.
A.
So, pneumococcal, it's non-live. So
A.
it's okay to give C.
It is okay to give C.
Yes, it's
D.
Yes,
it's
I'm
not a live
agreeing with
vaccine.
you.
C and D.
C and D. Yep, because those are not live vaccines.
Pneumococcal and meningococcal.
The C and the D. The rest of them are live vaccines. Day 2, nurse's notes at 8 a.m. The client received 1 unit of packed red blood cells overnight. His fever subsided after the administration of acetaminophen and the IV antibiotics, right? Awaiting platelet transfusions. The child is alert and able to consume small amounts of fluid. No new bleeding episodes were noted. You see his vital signs. They've improved, right?
Mm-hmm.
So his temperature's improved. His blood pressure's about the same. His heart rate has come down a little, probably because we gave him the IV fluids. His respiratory rate is the same, and his SpO2 is the same. The nurse reviews the client's medical records since admission to today to day 2 at 800 hours. Which of the following findings indicate improvement in the client's condition? So did he improve in his level of consciousness?
Yes.
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 Did his oxygenation improve?
The same.
It stayed the same.
They are the same.
That was the same. It was 96 on admission and
Yes.
96 now. Temperature?
Improved.
Temperature
Yes.
improved.
Did the petechiae improve?
Yes.
We don't know.
No, nothing was stated.
Nothing. Yep, nothing was stated about the petechiae and the
AC.
appetite. And he's waiting on the platelets, so we didn't do anything to improve that petechiae.
Yeah.
And then, so it's A, C, and what
And
about E?
E.
Yeah.
Yes.
That was
Yep,
And
his appetite improved.
yes.
The nurse is educating the caregiver on caring for the child at home. Which of the following statements indicates understanding or no understanding from the caregiver? So I will place colorful fresh flowers in my child's room to provide a stimulating environment.
No.
No understanding.
Yep,
No.
no understanding. I will include plenty of raw fruits and vegetables in the child's diet to boost his immunity.
No
understanding.
Understanding.
You're going to kill his immunity, right?
Yep.
No understanding.
We should join a cancer support group.
Yes.
Yes.
Understanding.
And
Yes. And they can join a parent group and a child group.
Yep.
The child requires regular dental flossing and teeth
No,
brushing
no.
with a
No
small.
understanding.
No understanding.
What part of that is incorrect?
Wait.
The
The
flossing.
flossing.
The
The
flossing.
flossing. Yep. The child should use designated utensils.
Yes.
Yes.
Yep. Yep. So that is the end of my presentation, and we are 1 minute over.
You.
Does
Thank
anybody
you.
have any questions?
So
Yeah,
just
I have
as
a
well.
request, Professor.
What's that?
Can we do some of the like Tybor question style?
Some more what?
Like a Tybor question.
I'm not understanding what
Oh,
you're
the
saying.
bow tie? You mean the
Bow
bow
Oh,
tie?
tie,
the
yes,
bow
bow
tie.
tie.
The bow
Sorry,
tie.
yeah.
The bow tie.
So the questions are provided to me by the team. I put the PowerPoints and the content together,
Mhm.
but the questions are provided by the NASLEX team, what they feel are most important. It's very hard to do bow tie on a PowerPoint. So we can kind of simulate. We're kind of doing bow tie when we're doing some of those understanding questions and anticipated, non-anticipated. But that would probably be a little difficult.
Okay, thank you.
It's not so much the types of questions as it is the content. We start at 7 o'clock Eastern time, and then there's another one. The NCLEX team said they will try to do some bow tie and see if it'll work. Again, you can get bow tie on the NASLEX site.
But yeah.
Because they give over 3,500 types of questions, and they are divided into your CATs and your readiness assessment tests. So you can get them on there. It's very hard to put that on a PowerPoint. It is a nominal cost, a very nominal cost for what you get. With the free tutoring, and then you get the slides and also all the questions. So the information is in the chat and the link is in the chat. You did a great job. Thank you. Thank you for telling me that. I try to make it, easy so that students can understand and get the points.
Thank you so much and have a
Awesome.
good evening. It was a wonderful.
You too. You all enjoy. I don't know if there's another session after this one.
Thank you, Professor. Good night.
You
God
are
bless.
welcome. Good night to you.
Thank you, Professor.
Thank you.
Thank you, Professor.
Thank you, Professor.
Good night.
You are welcome.
Thank you so much. I came late, but where I catch was very interested. Thank you so much.
You're welcome. So no, there is no other session tonight. The next one is tomorrow. And then Thursday I'm doing analgesic meds.
What time tomorrow?
I don't know what time tomorrow. You have to look at the site, and I think mine on Thursday is at 9 o'clock, I believe.
9 p.m. Eastern time?
Yes, 9 p.m. Eastern time. Yes, ma'am.
Okay, thank you.
You're welcome. Y'all have a good night. Yes, I'm 9 to 11 tomorrow. 9 to 11 tomorrow, y'all.
9 to 11 Thursday, I thought.
Tomorrow. Thank
Wednesday?
you, Ferdinand.
9 to 11 on Wednesday or Thursday?
Wednesday. And let me look and see. Mine is on Thursday. Oh, I can't put my hands on my calendar right this minute. Give me a second.
Are you doing pharmacology tomorrow?
I'm not doing anything tomorrow. I'm doing pharmacology on Thursday, and I am 9 to 11 on Thursday.
Okay, I thought you said you 9 to 11 tomorrow too.
No, somebody was asking what time tomorrow, and tomorrow is 9 to 11. Thursday, there'll be 2 sessions, and mine is 9 to 11 Thursday.
Okay. And that's pharmacology.
That's pharmacology. Pretty much after this week, I'm 9 to 11 the nights that I teach. Tomorrow is a different tutor.
Okay.
There's several of us tutors, and everybody is just as knowledgeable, and they all do well. So if you can listen into as many as you can, whatever will help you, right?
Right. I tried to pay for the Naxlex, but the subscription it wouldn't allow me to.
There's some Naxlex team on here. I'm gonna let him answer. If you give just a minute, he'll respond.
Okay. Bless you.
What was it doing that it wouldn't let you?
When I paid the $30, well, it wasn't 30, whatever it was I was trying to pay, it wouldn't go through. Like it was saying it was going through, but then it was like it was kicking back like a scam.
Okay. You can reach out via the Telegram group.
Okay.
Okay. Yeah,
Thank
I have
you.
nothing to do with money.
Okay.
I got enough issues. I don't want nothing to do with money.
Right.
All right. She can also share the WhatsApp. You can also share the WhatsApp contact, then he can share with IT.
Okay.
All
What is
right?
the WhatsApp? Just NCLEX on WhatsApp?
Yes.
Okay.
All right. You
Thank
all
you.
have
Have a
a
good
good night.
you too.
Thank you.